Hi, my name is Nicola Dunbar. I'm from the Aged Care Quality and Safety Commission, and I'm here to welcome you to this third in a series of webinars from the Commission and the Pharmaceutical Society. I'd like to begin by acknowledging the traditional owners of the lands on which we're all meeting tonight and pay my respects to the elders past, present and emerging. And I'd like to extend those respects to any Indigenous people who are with us today. As I say, this is the third in the series of webinars. Tonight, what we're going to be talking about are around community pharmacy programs and governance with respect to aged care. Thank you for the questions that you've put in for the previous webinars. We'll be coming back to you with those as soon as we can. We've got a really packed program with a lot of really great speakers tonight, so we may not have time for your questions at the end, but please put them in the chat as we go through, and we will come back to you with answers around those. So we're going to start tonight's webinar with Melanie Roth, who's the Chief Clinical Advisor at the Commission. Melanie, where can a pharmacist contribute to governance in an aged care service?
Oh, look, I barely know where to start with this question, but I'm going to just keep it with the aged care quality standards, which we've spoken to you about in webinar 1. But if the pharmacy activities are centred in the quality standards, then that is a very good way to get providers to understand and to pay attention. But standard 1 is the standard that puts the consumer at the centre, and I think that a pharmacist can really contribute to this by firmly framing the issues that they might see, problems that arise, and the solutions that they contribute to in terms of the consumer. Keep bringing back the impacts and the goals and the all of the systems to how they affect the consumer as individuals, and that's in terms of ascertaining their wishes, informing them, determining what reviews are necessary, and generally empowering consumers to be part of their own care, which is in that standard. Standard 3 is in relation to personal and clinical care, which has to be delivered in a safe and effective manner. And of course, medication management is a massive part of this. And that's where pharmacists can oversee and educate about best practice, tailor systems to the needs of the individuals and the current cohort of residents, and really look at things that optimise the health and well-being of residents in relation to medication management. Remind all of the stakeholders of the harms and risks associated with medications where there's an over-reliance on the potential and perceived good that medications do, and an under-perception of the risks and harms which weighs into the decision-making. Looking at such things as end-of-life contexts where goals may change and where symptoms are really what needs to be focused on, and of course antimicrobial stewardship. Standard 8 finally is a standard in relation to governance, organisational governance, of which clinical governance is a large and important component, and pharmacists can obviously contribute to MAC committees and more of that later, to generally looking at and highlighting areas of concern in terms of processes and procedures, flag areas for audit and education, quality improvement, assist with those activities, and reporting for quality indicators and the SIRS, or Serious Incidents Response Scheme, and any other internal mechanisms for oversight and improvement that the pharmacist will come across and be aware of.
Okay, thanks Melanie. So there are a number of programs within the 7th Community Pharmacy Agreement that affect residential aged care, such as a quality use of medicines program and residential medication management reviews. What evidence does the Commission see about these programs in action?
Yes, the Commission's in a very good place actually to see a large number of these reviews and QUM activities in practice. We get information from our outreach visits, from the quality assessor activities, which occurs in every residential service in Australia every year, and also of course through complaints. And we see the very best and probably the very worst of these things in action. So in terms of good pharmacist QUM activities in aged care, it's where the education and the reviews are in response to requests. It's a bespoke service. It's adapted to the needs of each service. It includes such things as MAC committees, information at all levels, from the board to the on-the-ground staff and to the consumers. Bad quality use of medicine activities are really where they're not occurring at all, or they haven't occurred for quite some time, where education platforms are meant to be used and have become inactive and not fixed, and where activities are general or repetitive, and they're dictated by the pharmacist rather than in response to what's needed at the ground. Sometimes the same activities delivered every year. In relation to RMMRs, the good ones we see where each consumer's unique position is understood by the pharmacist, where they are in their life, what current clinical issues they face, and which of those may be related to medication side effects or may be undertreated, and identifying where medication side effects may not be recognised and may lead to prescribing cascades, where medications contribute to falls, confusion, drowsiness, constipation, any number of things that this audience would be well aware of, where those things are recognised and called out. Where the consumer is involved either in discussion or in somebody who represents them if they can't speak for themselves, and that it's clear that the recommendation involves the consumer and that there's a clear rationale for why those recommendations are made, and the recommendations are prioritised. Bad ones we often see where any number of consumers have the same cut and paste information, where the low-hanging fruit is picked, for example, where the only recommendation is in relation to a PPI rather than any addressing at all of the concurrent 4 psychotropics that the person's been on, where the clinical input is out of date or absent. I've seen one where clinical information is copied and pasted from 9 months ago, and the date has been changed to a date that's actually after the review was performed, where the recommendations are clearly irrelevant to the person's condition, and where, when they're done remotely, there's been no clinical input at all from either the resident or staff. So those are just some examples of the range of what we see.
Thanks, Melanie. We've talked in previous webinars about the outreach visits that we're doing in remote locations that the Commission is running. What are some of the examples that you've seen through those where pharmacists are providing, really strong leadership and support around governance? Have there been things that you've seen in those visits that you particularly want to highlight for today?
I want to emphasise that it's not just our pharmacists that are doing this. So our pharmacists are interacting with pharmacists that work in aged care in every visit they go, in fact, and they're hearing about the activities that are being undertaken, some of them very, very specific and bespoke and interesting. So, we see a lot of helping staff understand the harms of the medications they're using, particularly in the context of PRN administration decisions, where obviously the administration is discretionary, and the staff may have very limited understanding of what they should be using it for and what might be the potential impact. To help staff understand the impacts on somebody's communication, alertness, function, recognising constipation, falls, balance issues, nutrition, wound healing, infection, all of those things that medication can impact on, and that there may need to be education, either formal or informal, given, and usually very much appreciated. There's a great thirst at the moment for information on consent, and the information required for consent increasingly now by consumers, and clearly a pharmacist has a role in assisting with that information. Identification in systems of how date control is managed, expiry dates, for example, and the storage needs of various medication, where things that don't need to be refrigerated are being stored in large quantities in fridges that are overpacked. Advice on deprescribing, when you need to taper, when you don't. highlighting tools and strategies, Schedule 8 systems where things are happening that might not be legal and might not really govern for the risk of misuse and theft. We've come across the use of bush medicine and the interaction. People are quite concerned about potential interactions with other medications and traditional healing. MAC set up an advice, obviously, which we'll come to. A whole lot of issues in the regime simplification. For example, if all the morning medications are given at 8 o'clock and the round takes 2 hours, well, there'll be a number of people who think they're getting their medications 2 hours late. So sorting the logistics of that, highlighting where things don't need to be given 3 times a day when there's a slow release or a longer acting preparation. Advice around swallowing problems, alternatives, when medications can't be taken or aren't wanted, and of course discussion with GPs and prescribers about the needs for updates in medication management, but the needs of consumers in residential aged care. So that's a sample of the range, but most of those won't be new to pharmacists in general, but they can really be leveraged well in aged care.
Okay, thank you. We'll move on to one of the particular aspects that you've flagged already a couple of times in your answers about medication advisory committees. We have joining us tonight Professor Michael Dooley, who is a hospital pharmacist with a strong interest in MACs. Michael, can you tell us why a MAC is so important in residential aged care?
Yeah, look, I think the key bit is we've just heard really clearly all the things that can go right and all the things that can potentially go wrong. And I think in a lot of settings we have those scenarios where we have a lot of practitioners who to some degree can be practicing independently. You can have, the GP, you can have the nurse who may be isolated in their own practice. You may have a pharmacist who may be coming into the facility at different times, community pharmacy, the patient, the consumer, their family. You can have a whole range of independent individuals entwined. And sometimes that works really well and you have the right, really switched on team of people that just the sweet spot is hit because of the GP and the pharmacist and everyone working well together. And I think that's fantastic, but it doesn't always happen. And I think where MACs are as a group is really in those circumstances, or the value is to pull together those people who are maybe practicing very independently and pull them together and pull them together in a way that aspects of safety and quality are addressed. And so that, those processes that need to be in place that maybe aren't occurring, those practitioners who may not be necessarily prioritising what they need to do, the quality of a service may not be there, a carer's care may not be as good as it should be. That's what a MAC's for. A MAC is to pull the groups of different practitioners, the interdisciplinary, multidisciplinary practitioners together, not all of them, but and allow that a focus to be able to draw and drive quality and safety. So to take that broader view from the individual to what the service and what all the carers are receiving, and be able to support those independent practitioners, whether that be by supporting collaboration, by supporting communication, by understanding the needs of the various groups and pull them together. So rather than a committee that often they're seen to be of people being just focusing on little things, I believe that the quality of a MAC is where it actually pulls people together, provides that opportunity for communication and sharing about the quality, and then supporting the individual practitioners to be able to provide what they want to do is better care. To do that, they have to develop guidelines and they have to promote and monitor and evaluate and look at instances and do all those type of things. But it really is where they're effective is really where they add value to the practitioners, focusing on the impact on the carers and the impact on those that are receiving the care. So it's very much a process to be able to support better care by bringing practitioners together and those that are involved in making decisions about medication use and safety within that organisation.
Okay, so that's great. Thank you, Michael. That really explains it well. So to achieve that as what the outcomes are that you're trying to achieve, what would be the key features of what makes a MAC effective? What are the things that need to happen to get to those outcomes?
I think the key thing is the MAC has to see that as their role, is the fundamental. If you put together a MAC that has people not really interested in that and aren't engaged in trying to improve quality and safety, then it's not going to be effective. It's going to be a governance process that doesn't add value. So the most important thing is the MAC and those that are involved in it, and especially those who chair it, are actually engaged in the quality that they're trying to provide. So, for example, I always think that it's important to have a practitioner as chair of the MAC. And what I mean by that, it doesn't mean that it can't be someone within the organisation at a senior leadership position, but maybe it needs to be the GP. Maybe it needs to be, the pharmacist who comes in. It's all about the chair and the rest of the team believing that they're there to actually do what I've just described, and that is support and bring together the various practitioners. If it's just seen, if the MAC just thinks it's there to audit, or if it's just seen to write a procedure or to get ready for some audit process, that's not what I believe a MAC's for. So the key bit is those on the MAC have a focus on quality and safety, and that their focus is on supporting the practitioners to deliver the best care. Now, to do that, then they have to do all the things that a MAC needs to do from a process perspective. But the underlying thing, like any committee or group or group of experts, is to make sure that they have principles that they go back to. And every group, every MAC, should be able to really articulate the 2 or 3 principles that is describing their decision making. Not describe the 12 audit processes they're going to do, but describe the principles of why they are getting together. So they should be able to describe that they're there to improve the care and safety of those that are receiving the care. And secondly, they're there to facilitate the communication and collaboration between the practitioners. So that should be the focus. And a good MAC should be able to do that, and it should be led by, most of the time, not always, by a practitioner who is also living and breathing and has an understanding of the challenges and the benefits of that patient-facing role. The rest of it, the detail, the agendas, the indicators, those components will flow as a secondary. So I think the most important thing is the people on the MAC having and focusing on the key principles of why they're there. If they can't do that and they're not focused on that, need different people on the MAC.
Okay, fantastic. Thank you very much for that. That's really clear. We'll move now to one of the other examples that Melanie spoke about around residential medication management reviews. And I'm going to now go to Dr. Janet Sluggett, who is a Senior Research Fellow at the University of South Australia. Janet, what is the recent evidence about the provision of RMMRs in Australian aged care services?
Yeah, thanks very much, Nicola. So as you've mentioned, as part of my research and along with the team that I work alongside at the Registry of Senior Australians, I've had the opportunity to use big data to really understand both the uptake of the program nationally and also the health outcomes for residents that are associated with the program. And so I've done this, as I said, using ROSA, which is an aged care registry. And so an aged care registry is really a big linked health database that includes information about all the residents who access aged care services nationally. And so it links together information about their medicines, their GP visits, the types and dates of aged care services that they access, and also information about their hospitalisations and mortality. So I guess by pulling all that information together, we can see a whole picture of a person's ageing pathway and what the medication use and RMMR uptake looks like for that individual. So we've done a number of studies. So just to give you a key sort of brief synopsis of what we've done, we've been able to answer a number of questions using our data set. So we've been able to look at, well, how many people actually receive a home medicines review in the community setting before entering an aged care home? And then once they enter the aged care home, how long does it take for the resident to receive an RMMR? And how does that uptake vary across facilities? And then we've recently completed a piece of work that's been commissioned by the Australian Association of Consultant Pharmacy. And we sought to answer questions like, well, how do trends in medicines use change after a medication review? And what is the link between RMMRs and some of those important longer-term health outcomes like hospitalisations or mortality? And so just to give some brief highlights of what we found with that work, I guess in terms of highlights, we found that when looking in the year before a person enters an aged care facility, only 4.5% of older people actually receive a home medicines review. And that's despite the fact that we presented research to the Royal Commission around increasing use of psychotropics in that year prior to entry. And so what we found subsequently is there is very low uptake of the program in that year prior to entry. And then once a person enters the facility, even though it's generally recommended that everyone receives a medication review on entry to the aged care facility, what we found was nationally in the first 3 months of entry, only 19% of residents, so 1 in every 5, receive an RMMR in the first 3 months. And that does vary between facilities. So in roughly around 10% of facilities, so that's nearly 300 of the 3,000 almost facilities that were included in our studies, no residents received a medication review in that first 3 months of entry. So in 10% of facilities, no uptake on entry. And then in only a small proportion of facilities, 6%, did we see that medication reviews were provided to more than half of all new residents. So although there is some variation, there's definitely overall a lower rate of provision on entry. And so obviously that's a missed opportunity for us to be providing RMMRs for those residents, and people are missing out. And then just to touch on some of our other key findings in the project work that we did for the AACP. So what we found was we looked at medication use changes in people who received a medication review in the 6 to 12 months after entering a facility. And what we found was in those who received an RMMR, there was a modest drop in the use of certain medications. So things like proton pump inhibitors, statins, benzos, benzodiazepines, calcium channel blockers, and antidepressants, compared to people who didn't get a medication review. And so I think that finding was really encouraging, but we didn't see any major changes in the overall use of other medicine classes. So things like diabetes medicines, osteoporosis medicines, treatments for dementia or other types of cardiovascular medicines. So obviously the reasons, we don't know the exact reasons why there was a less or a limited impact on some medicine groups. But I think it really suggests that as accredited pharmacists, we really need to be alert to, certain types of high-risk medicines like opioids and antipsychotics and insulin when we're doing a medication review, and also using strategies to make sure that our recommendations are tailored to individual residents, and also that our recommendations are acted and follow up on. And I guess just to finish, to highlight our outcome study results. So in the same individuals, we didn't find any links between hospitalisations over a 12-month follow-up period, but we did find that receiving a medication review in the 6 to 12 months after entering a facility, it was associated with a slightly lower risk of mortality among people who received a medication review, so around a 4 to 5% reduction in mortality. And so I think it's important to note that, overall we've been able to look at the impact of initial medication review, but we haven't yet been able to look at the impact of the follow-up visits. And so I think that's obviously an important area for us to be looking at in the future, and also any other program refinements and how that might impact on health outcomes for residents.
Thanks, Janet. It'll be really interesting to hear about how how this study progresses, because obviously you've already found some really fascinating results, and the results that show the small uptake, quite a low proportion of uptake of the RMMRs is really quite concerning. Do you have any ideas, or did the research kind of give any sense of why there has been such a poor uptake of these reviews?
Yeah, definitely. So I think there's been a number of studies which have raised some of the barriers and enablers to providing the RMMRs in aged care homes. And so I think there's the obvious ones that all accredited pharmacists would be aware of, no doubt. So it's things like, a low level of remuneration for the service, the requirement for a referral from the GP, and also sometimes a lack of awareness of the service among some GPs or providers of aged care services or residents themselves. I think another one that accredited pharmacists would be acutely aware of is the impact of program rules and how that can impact on the service. So we've actually published on this recently, looking at the impact of program rules and trends in RMMR provision in older Australians in aged care homes. And what we have found is that although, as accredited pharmacists would know, there's been an increase in collaborative medication reviews after the 2011 program changes, there was a significant decrease in provision after the 2014 changes. And the rates of RMMR provision in that population have really only just started to reach those in the pre-2004 levels in the last couple of years. So there's some of the general barriers. I guess some of the enablers that we found, not just from the literature, but also from our medication simplification work in aged care, is really highlighted the importance of good stakeholder and good working relationships between pharmacists and GPs and aged care providers. And I think, having the ability to have those face-to-face discussions around preferences for medication reviews and other types of recommendations so that we can facilitate RMMRs that are valued and more likely to be acted on in practice, because that's the ultimate one of the goals of the work. And I think we also know from researchers like the work done by Dr. Mona Sawan, who's looked at the links between poor organisational culture and also aspects of medication management and psychotropic use and medication reviews, that, organisational culture in aged care homes can also contribute and be a barrier or an enabler to the uptake of reviews. And then I guess just to finish in our research that we've done looking at provision of a medication review on entry to an aged care facility, we did find that there were certain resident characteristics that were more likely, more associated with receiving that service on entry. So what we found briefly was, people with dementia, living with dementia, and those who speak a primary language other than English were slightly more likely, 4 to 5% more likely to receive an early RMMR. And as were people who take a greater number of medicines and those who need more assistance with medication management and administration. So I think those are really encouraging findings. What we did find, though, that was people living outside a major city, so in a rural or remote area, they were 30% less likely to receive a medication review on entry. And so that's possibly related to workforce availability. And in our unadjusted models, but we didn't include this in our final regression models, but we did find some evidence of state and territory variation. So, for example, residents in facilities in South Australia, WA, Northern Territory and ACT were less likely to receive medication reviews on entry. And then finally, I think one of the other factors just to finish up on is obviously it's important that the Royal Commission did note that we need to have strategies implemented around RMMR quality. And I think that's something as accredited pharmacists we need to be aware of, because obviously, we need to have high quality reviews so that they have the best chance to be acted on and improve resident outcomes.
Okay, thanks very much. It was really useful, and as I say, it'd be interesting to hear some more about your research as it goes along. I'm going to now bring Juanita Breen into the conversation. Juanita's spoken in these webinars before about the findings of the Royal Commission. And Juanita, can you take us back a step around particularly what did the Royal Commission find around these issues around medication management in aged care? We've covered kind of a range of different things so far. Can you give us a bit of an overview about that?
Thanks, Nicola, and good evening, everyone. I just wanted to say that inadequate medication management was referred to quite a few times in the final summary report of the Royal Commission. In general, they reported that substandard care occurred too often, both in routine areas of care, like in overall medication and prescription management, but they also spoke of inadequacies in complex care, such as the management of chronic conditions, dementia, mental health, or palliative care. And we know medication is a mainstay in the treatment and management of all these areas and conditions. The final report also contains a special dedicated paragraph regarding the management of medication in aged care. And I'm going to read it out because I think it's quite powerful. With people living longer and the increasing prevalence of multimorbidity, older people are more likely to be taking medicines. And in some cases, they're more likely to be taking multiple medications daily. Often older people need assistance to take medications correctly. We heard numerous instances of inappropriate management of medication regimens. We heard about aged care staff members failing to administer medications correctly or administering medicines but failing to ensure residents swallow them. We heard of failures to administer medicines at the correct time or in the correct dose, and of residents being administered incorrect medicines. Another thing that the Commission final report analysis focused on was on restrictive practices, which are activities or interventions, either physical or pharmacological, chemical, I think is another way to describe it, that restrict a person's free movement or their ability to make decisions. And they highlighted that these practices had been occurring for over 20 years and that significant attention and action was really needed to curb their widespread use. Now, I'm going to just report on one case because I testified at the Royal Commission, and one of the lawyers sent me a couple of cases, but one has really sort of stuck, and that's of Mrs. Margaret Barton. And I was asked to comment on a coronial report, and it was over some 60 pages. It's still available online if anyone wants to read it, looking up Margaret Barton, and I think it's from Victoria. I wasn't prepared, so I waded further into the report. I became very dismayed about the appalling medication management that I read. I'll just tell you a little bit. Mrs. Barton was recently admitted to the residential aged care home. She had dementia and what I think was obviously a delirium. Her behaviours were very difficult to manage. Her treating GP prescribed PRN doses of oxazepam, 15 milligrams 3 times a day. But they were given out by nursing staff 3 times a day. After a week, he added a regular oxazepam 3 times a day to her chart, but didn't alter the PRN charting. So for 2 full days, her oxazepam dose amounted to 90 milligrams a day, which is about 3 times what's recommended for an older adult. Other doctors became involved in her care after that. So over the next week, they added several antipsychotics along with an antidepressant and 2 opioids. Mrs. Barton actually fell on 8 recorded occasions at the home, and she ended up in hospital with pneumonia after a few weeks after admission. And on her final x-ray the day before she died, they found 3 recent vertebral fractures, a hip fracture, and rib fractures. And the coroner in his report concluded that excessive oxazepam use was likely responsible for the falls and resulting fractures. On the whole case, there were multiple doctors, at least 4 that I counted, and quite a few nurses associated with medication prescriptions and administration, but I couldn't find a single reference to a pharmacist. So multiple high-risk medications which didn't seem to be working, falls, adverse effects. And I couldn't help thinking, where is the pharmacist? You know, why are what we call ourselves the medicines experts sidelined? And further, you know, I just wondered why Dementia Support Australia wasn't called, or a psychogeriatrician. And I was going to just finish up by saying, although this case is admittedly extreme, I still see multiple instances of a psychotropic pharmacy given to frail older people. And I see multiple instances where referrals are not made and pharmacists are not considered to be really part of that treating team. And I just wanted to end by saying that this case of Margaret Barton really shows that we should be. Thanks.
And thanks, Juanita. I'm actually going to ask you a question that's slightly off script, but I think what we've talked about so far in terms of things like the medication advisory committees and the RMMRs are obviously tools that would, if they had been used in that case that you described, would have made a difference, one would think.
Oh, definitely. Around the PRN use as well, it's written on the PRN chart. That doesn't mean it has to be given on every single occasion. And, when something is written on a regular chart, you should be reviewing the PRN chart as well. And that was massive overdosing and obviously contributed to the fractures there. But there are so many instances there, and you think that if you had a medication advisory committee, you would say, look, if you've got real problems with a particular resident, and especially in that case, call a pharmacist somewhere, or an expert, or a psychogeriatrician, and it just showed sort of like a whole series of I suppose, issues around medication management that weren't dealt with. And then instead of sort of reviewing whether one medication worked, which obviously they didn't, they just added more and more and just added to the whole regimen, and it really ultimately contributed to this lady's death. Margaret Barton.
Okay. Yeah, thank you. That's such a powerful story. Thank you very much. We're going to just change pace slightly now again and welcome Mariana Crank to this webinar. Mariana is a Director of Pharmacy Programs in the Technology Assessment and Access Division of the Department of Health. Mariana, we've been talking about RMMRs. Can you tell us about why the RMMRs are restricted to one a year and to one contracted pharmacist or pharmacy provider for each aged care service?
Hi, thanks. Well, they really aren't, because, a RMMR can be referred at any time on the basis of clinical need. And I think that's, the key part here. There's a lot of clinical need, as we've just discussed, and it's very important that there's a collaborative approach, and keeping the patient at the centre of that collaborative approach, and the GP is also key in undertaking, reviews of medication. Now, the other thing I did want to highlight, which has been touched on so far, is obviously things have changed over the last couple of years a bit with the RMMR program. We've had the program running for quite a long time, but last year we introduced funded follow-up services so that there could be up to 2 follow-up services funded after the initial review. Now, that really sort of takes it from a one-off to providing some funding to follow up on issues after you've done a comprehensive review, and really more of a bit of a cycle with the RMMR program. I will also touch on what you've said there about only one provider. Back also when we introduced the follow-up reviews in April 2020, as part of the government's response with the interim report for the Royal Commission, we also expanded so that more than one service agreement can be in place. That's to sort of help support choice of provider and the pharmacist. And we also expanded the referral pathways so that obviously many are referred by GPs, but there might be instances where a specialist such as a geriatrician may wish to refer for an RMMR, which obviously it would be appropriate, and also, to help assist with transitions of care if, say, a medical practitioner from a hospital wanted to refer for RMMR. So all those medical practitioners can refer for RMMRs.
Okay, fantastic. It's really good to get a clear sense of the changes to the program and what's going on with that. Can you give us an indication of what might be in store around pharmacy programs moving forward?
Sure. Well, as I've mentioned, we have had those changes that were put in place in January and March and April. So obviously there's those follow-up services that were introduced for the RMMR program, up to 2 funded follow-up services after each initial review. Those will be ongoing, and also those changes I've just mentioned with RMMR about providing choice and providing for a range of medical practitioners to refer. Also with the back in March with the HMR program, even though I know that's outside of aged care facilities. Obviously, that's a large part of managing aged care in the community. We introduced the follow-up services for HMRs, the home medicine reviews, and also we increased the cap on those programs so that pharmacists can undertake 30 up to 30 a month from 20. And also the funding for the Quality Use of Medicines program under the 7th Community Pharmacy Agreement was doubled in January last year. So all those changes, you know, they're not the answer to everything, but they're steps in the right direction, and those are ongoing. Looking forward, obviously there's many findings that are pretty serious from the Royal Commission. The government has responded to some of those, and obviously there was a lot of changes that will be coming out of that big budget announcement from earlier this year. But there's a lot more also in the Royal Commission and the findings for the government still to consider and to respond to. And you know, the government is still considering what further might need to be done to assist with managing medicines. Not just with, you know, what has been found as issues and made as recommendations with regards to the RMMR program, but there's other aspects that affect pharmacy, such as, you know, one of the recommendations was to have pharmacists on site at aged care facilities, and that's something the government is still considering at this point in time.
Okay, thank you. That's really useful. I'm going to go back to Juanita now in terms of these kind of range of different quality use of medicine programs and services that exist. Juanita, how can we be sure that consumers and providers are getting the best? What kind of approach can we take to make sure that people can get the best out of these programs?
I think that the range of services that can be offered as part of the Quality Use of Medicines program is quite broad, and it ranges from audits, quality improvement initiatives, of course involvement in the Medication Advisory Committee, staff and resident education, informal medication counselling, setting up things like in-press cupboard, and working with services on medication policies and procedures. I just wanted to say, as part of the clinical pharmacy unit, we've been delivering quality use of medicine services in a different way, but you know, we visit a service and we spend usually a day or two at most, and I've really been trying to pay attention to the standard one, which is really involving the resident who is central to their care, and I've started to offer relative and resident education sessions. It's still a bit tricky to sort of cater these to ensure that the content is relevant and understood, but on the whole I find that they're very, very well received. I've been bombarded by all these questions at times. Often I've found recently about COVID vaccinations, and I think that they really do like the opportunity to talk to a health professional. But on the whole, I think these talks are really appreciated. One added benefit I've found, you know, when I give the resident and relative education sessions is that a lot of the time the consumers want to communicate their concerns about medications and treatment to a staff member, and I usually ask for the staff member to attend, and often sort of like both benefit because they realise what is concerning the residents and relatives. I think one of the things that's come up in this conversation is about how quality can be assured. And I know that the Pharmacy Programs Administrator has an audit and compliance section, and they work to ensure that the program rules are met. But they're more sort of practical supply things, like that a contract is held with the service provider, or with regards to RMMRs, that a accredited pharmacist conducts the service, or that the maximum cap number of services is not exceeded. But at present, there's limited quality control, really, in terms of the clinical quality of what services are provided, the quality of what's provided as QUM, or what exactly is provided. And I know there is some discussion at present, as the Royal Commission did call for attention and focus on the quality of service provision, not only on the supply. But I did want to sort of say that if providers and consumers are concerned about the QUM service or a lack of a service, they can call the Pharmacy Programs Administrator. There's also an anonymous tip-off section. During our clinical pharmacy visits, we're starting to tell providers what they're entitled to and to talk about what can be offered as part of QUM in any case. If a particular person has a problem with a pharmacist or a pharmacist recommendation, they can go to AHPRA and place a complaint about the professional conduct of any health practitioner. Okay. Thank you.
Thanks, Anita. And I think this issue about how providers and consumers can get the most out of quality use of medicines, how can we make sure that we get the best outcomes out of these processes is really important. And Melanie, I imagine that you would have seen some stories around this, both in terms of the pharmacy visits that we've been doing, but probably as part of your own practice as a geriatrician. Do you have some stories that might be a counterpoint to Juanita's story about Margaret Barton, perhaps, that actually are good examples of where things have gone well?
Yes, I actually do have some stories. Some will be familiar and some are a little bit more quirky. But some of the particular systems issues that we've come across and solved. One that comes to mind is there's an island nursing home where the residents were all Aboriginal, and there was no confidence and no good palliative care processes. The staff didn't feel that they could do it. They didn't feel they had the local support or knowledge, and so these elderly people were routinely being transferred to the mainland for hospital care when they came to the end of their lives. And clearly the cultural implications of these were terrible, where their relatives could no longer visit, and also they were not given the opportunity to die on their own land. And it was quite a distressing issue for the staff. And a pharmacist came in with a really good problem-solving approach and realised the incredible impact this was having, and was able to discuss the use of syringe drivers, to access the training, to liaise with the local hospital palliative care team to enable an initial visit, and then also to be able to get outreach support, which of course was mostly remote, so that transfer was occurring rarely and only really in cases where the pain or other palliative needs were not able to be managed on site. And at a subsequent visit, they were so pleased that they could offer this service that staff really felt empowered, and that was just a fantastic outcome. It was completely pharmacist-led. I want to talk about mangoes in another, a completely different state, but another Indigenous service actually, where a elderly woman who was relatively new was being discussed, and the pharmacist was asked to assist because they wanted to use chemical sedation for this woman, chemical restraint, because she was getting agitated and kept on coming out at night and disturbing the other residents, saying that there were boys throwing stones on the roof of her room. And she was really labelled as being paranoid and possibly delusional, and that they felt that she needed some sort of medication to help her sleep and stop these strange thoughts coming around. And when the pharmacist went and spoke to her and actually wondered whether in fact if mangoes could be falling on her roof, because there was an overhanging tree, one with nuts and one with mangoes, which was the case. So she wasn't paranoid. There were things falling on the roof. She was misinterpreting it as boys throwing rocks rather than mangoes. But when this was drawn to the staff attention, she was given a new room, and her so-called paranoia and need or not need for chemical restraint went away completely. There was another elderly man who was very problematic to the staff, because from their perspective he was completely able to toilet himself, but he was deliberately soiling the floor. So he wasn't using the toilet, he was opening bowels on the floor, and that this was clearly behaviour that needed to be sorted out. And I'm sure you've all guessed it, but the pharmacist had a good look at the medication chart and was able to identify several laxatives all being used at the same time. And when that stopped, he was able to get to the toilet in time. It wasn't willful misbehaviour. Another example is with diabetes, where a pharmacist can recognise that the control may be much too tight, which is both risky in elderly people, and I know I'm preaching to the converted, but risky because they may not recognise and be able to respond to the signs of a hypo, which may happen fairly easily in residential aged care and have catastrophic consequences. So identifying that and being able to allow the staff to relax to respond with food, but also to relax the tightness of the control, change the criteria. And the converse of that is where somebody is wanting to eat and the nursing staff are saying no, because your sugars are too high anyway, so we don't want you to eat. And of course that's the nursing staff imposing their will and their knowledge on the resident who actually did want to eat, and before he came into the nursing home he did eat, and his control wasn't great and he knew it, and that was his choice. But of course also medications can be adjusted to respond to somebody who eats more, and pharmacists have a huge role in that. And another story that comes to mind is during a COVID where a resident had a fall, and the nursing staff did wonder whether there was a medication involved in this person's tendency to call, which is fantastic that they did involve a pharmacist to ask if a new symptom could be related to medications. And this was a person who, during a COVID outbreak, when everyone was required to stay in their own rooms and where a significant number of staff had been furloughed, so staff looking after people didn't actually always know what their needs were or know what was normal for that person. And this woman needed assistance to eat. She needed to be fed. The carers didn't know that. That wasn't part of the handover. So she wasn't fed. The kitchen staff took away uneaten meals without telling anyone. And the resident, needless to say, was having recurrent and fairly severe hypoglycemic attacks, which were manifesting by falls. And again, that was an issue that a pharmacist was able to unpick and sort out. And you can really see that these things are not difficult for you as long as you know and you're asked, and that your ability to inquire more deeply into things that are going wrong for people and things that are going wrong for services is of such good value. And I know that the question is not going to be what can you add, it's going to be how can we get you more involved, how can we get providers to recognise these things and GPs to make referrals. So having seen some really brilliant RMMRs, and this is just one way, I think that in some cases the market will talk, and if GPs see a good RMMR, they're much more likely to refer for future ones, and if they see a bad one, it may be the last one they ever refer for.
Okay, thanks, Melanie. I think it's useful to kind of see that connection between what happens on a day-to-day basis between a pharmacist and a resident, and how that can be translated into the kind of bigger governance processes within a service to kind of build those things in an ongoing way, so that this is just the way things happen. We're coming to the end of our time, and so, Melanie, we've got the last one of the series of webinars in February next year. What is going to be coming up for that one?
Okay, so next one is the last of this series of 4, and we're going to be focusing somewhat on polypharmacy and interactions, etc., drug burden index, particularly in relation to how the pharmacist can help with deprescribing, and a little bit of antimicrobial stewardship, and to introduce one of our new programs that pharmacists can deliver. And also we will be talking about a few tricky medications, so medications that are common in residential aged care and that are often misused, such as gabapentinoids. A hot topic that's coming up more and more in questions to the Commission is the use of medicinal marijuana in some expected and some quite creative contexts, should I say, and causing some concern and arguments between relatives and GPs and aged care staff, but that's another one. Then, of course, the use of patches, particularly where they have a high potential for misuse, and diversion to the black market diabetes medications and end-of-life care medications, and the use of syringe drivers in the aged care context. So that's a few things in the next webinar.
Fantastic, thank you. Oh, sorry.
No, I was just going to say, you all deserve a break and a very happy Christmas.
Yes, indeed. And so before we say that, I'd just like to say thank you very much to the panel today, to Michael, Janet, Mariana and Juanita. I think it's been a really wide-ranging and useful discussion. And as Melanie says, everybody, I think at this point of the year, definitely deserves a break, and thank you very much for participating in this webinar and in the other ones that we've had, and see you in 2022. Thanks very much.